So now let's start looking at another case. A 64-year-old man. Now, the 64-year-old man, we know that he is at that age where osteoarthritis can be an issue. So that's one of the diseases that we're going to keep in mind right away. The man comes to you for evaluation of knee pain. He tells you that he has had right knee pain for many years, but recently it has gotten worse. So the patient has had this chronically, only the right knee, chronic. He denies constitutional symptoms, so there is no fever, malaise, any other symptoms that would indicate any other disease. He doesn't have any hair loss, oral ulcer. He doesn't have anything that would indicate an inflammatory process. And other joint pain except for his left, second, and third distal interphalangeal joints. Now, as we can see, the distal interphalangeal joints are affected in this patient, so we're not going to think, even if we were thinking of an inflammatory condition, we're not going to think of rheumatoid arthritis because the distal interphalangeal joints are affected. Now, he has not noticed stiffness in the morning. So little or no stiffness in the morning actually goes with the diagnosis of a non-inflammatory type of disease. On examination, you hear crepitation as you move his right knee, but otherwise, there is no evidence of swelling, warmth, or edema of the knee. So basically, no local evidence of inflammation either. His laboratory testings is unremarkable. So no elevation of ESR. So definitely this is not an inflammatory condition and is affecting not every joint. So it's not symmetrical. It is not inflammatory and it's not infectious type of condition. In an older patient, it's going to be osteoarthritis. Now, a couple of high-yield type questions. What is the most important modifiable risk factor for secondary osteoarthritis? Which of those conditions is the most modifiable in secondary osteoarthritis? Rheumatoid arthritis, obesity, trauma, hemochromatosis, or acromegaly? The one that you can modify the best, or there is a possibility of modification, is going to be obesity. After the trauma is done, you can't take the trauma back, right? So that wouldn't work. So most likely obesity. Now, which of the following joints is characteristically involved in osteoarthritis, but it is not involved in rheumatoid arthritis? Remember, what is the joint in the hands that is not involved in rheumatoid arthritis? And that would be the distal interphalangeal joints. Now I can change that question backwards and says, which of the following joints is characteristically involved in rheumatoid arthritis, but it is very seldom involved in osteoarthritis? And that would be the metacarpophalangeal joints. So again, osteoarthritis usually doesn't affect the metacarpophalangeal joints. Rheumatoid arthritis usually doesn't affect the distal interphalangeal joints. Again, osteoarthritis is the most common joint disease in humans. It actually comes with age, and if you're lucky enough to live a very long life, you are all going to have osteoarthritis. Hopefully not, but most likely you will. It targets the tissue basically of the articular cartilage. So it's actually the cartilage that is going to be damaged initially. There's destruction of the cartilage along with secondary remodeling and hypertrophy of the bone right under the cartilage. So what happens is that the cartilage is completely destroyed and then there's just bone to bone. And that bone actually develops a shiny kind of ivory appearance to it because of the constant grinding one bone with the other. It is not an inflammatory disease. And remember that the most common joints that are going to be affected is going to be the knee or the weight-bearing joints. Also, the base of the thumb can be affected. So what are the most common risk factors for osteoarthritis? Well, age is the number one. If you happen to live a long life, you're probably going to start getting osteoarthritis by the time you're 50, 60, or 70. Female sex is much more prevalent osteoarthritis than in men. Genetic factors can actually predispose to osteoarthritis. So in certain families, you would see that osteoarthritis actually occurs at an earlier age. Major joint trauma can actually lead to osteoarthritis later on in life. Repetitive stress. So joggers actually will get a lot of osteoarthritis in their knees before they would usually get it if they would not have jogged. And then obesity is another one of the risk factors that is very easily modifiable. Now, how do we classify osteoarthritis? There's usually two types. It's either idiopathic or secondary to something else. The idiopathic form is the most common form. There is no predisposing factor and usually occurs as the patient actually ages. Then there's a secondary form, which is indistinguishable from the idiopathic one. Any disease that causes stress or trauma to the joint will eventually lead to osteoarthritis. So things like gout, diabetes, acromegaly, hemochromatosis. If the patient has a deformity of the joint, such as valgus or varus deformity of the joint, then these are things that actually are going to put stress on the joint. And sometimes in valgus and varus, it can be on one side of the knee more than the other side. So as far as the clinical presentation, the major joints that are going to be involved are going to be the weight-bearing joints, the hip and the knees. Remember, we said that the knee is probably the most likely joint to actually develop osteoarthritis more than any other joints. Then the small joints of the hands, the distal interphalangeal joints and the proximal interphalangeal joints. Remember, osteoarthritis tend to spare the metacarpophalangeal joints. Now, the joints is affected in an oligoarticular asymmetrical pattern. So it's very different than rheumatoid arthritis that affect the joints symmetrically. In these cases, it is asymmetrical, and it could be also monoarticular. Maybe only one joint could be involved in the patient. Joint involvement is actually very slow, so it's a very slowly progressive disease, but it does tend to progress, and it's actually irreversible. There's nothing much that you can do once the disease is there, unless you actually end up having surgery and joint replacement and so forth, but not really a disease that is reversible at all. Some further characteristics about osteoarthritis is that the joint pain increases with exercise. Just remember, grandma doesn't like to go play basketball. It is too painful. Grandma doesn't like to walk on the airport for miles and miles to get to the plane. Grandma actually asks for a wheelchair to get her there because the pain is too much for her. And usually the pain is relieved with rest. So grandma is sitting all the time in one place and she doesn't like to move too much, right? So think about those things. Remember that the morning stiffness in those patients are less than 20 to 30 minutes. Usually 10 to 15 minutes is all that there is. There could be crepitus in the actual joint itself. Loose pieces of cartilage can cause sort of a grinding type of sensation when you do passive range of motion of the joints. And there's no systemic manifestation in osteoarthritis. So these patients are not going to have weakness, malaise, fever, or anything else that would indicate an inflammatory process. What are the laboratory tests in osteoarthritis going to show? Well, basically nothing. It's going to be normal. There's not going to be any indication of inflammation. There's not going to be an elevated ESR or a C-reactive protein. So these patients actually are not going to have any evidence at all of inflammation. And the diagnosis is made using just clinical criteria and x-ray findings of the joints. And the x-rays will show the typical osteophyte formation, the joint space that is narrowed, and eburnation of the subchondral bone. And you'd see that the bone below the cartilage is a little bit wider in the x-ray, so more radio-opaque than the rest of the bone. And those are typical characteristics of osteoarthritis. And that would be how we would determine that it is osteoarthritis. So laboratory test doesn't help in this disease. Now, the American College of Rheumatology has put out a criteria for the diagnosis of osteoarthritis of the knee. I know that you don't have it in your book, but I wanted to include it here in this slide so that you can actually follow this, because these are actually can be used for other joints as well. Knee pain should be present if it's osteoarthritis of the knee that we're thinking about. Knee pain plus 3 of the following. Either the patient is greater than 50 years old, the morning stiffness is less than 30 minutes, there is crepitus of the joint, there is bony tenderness, so there's tenderness over the bone, there's enlargement of the joint, and there's no palpable warmth of the joint. Because if there would be palpable warmth, that would be an inflammatory process. So 3 of those plus the joint pain usually would indicate osteoarthritis. And these are criteria put forth by the American College of Rheumatology, which is standard of care for rheumatology. Now, which of the following is a characteristic of osteoarthritis? Is there eburnation or hypertrophy of the subchondral bone? would the bone look a little bit more dense than the rest of the bone, as opposed to in rheumatoid arthritis, where there is periarticular osteopenia. And in osteoarthritis, there's definitely eburnation or hypertrophy of the subchondral bone. Is there loss of joint space? Remember that in osteoarthritis, what happens is that the cartilage is affected and it just completely disintegrates. So definitely the cartilage is what keeps the joint space intact. So if the cartilage is disrupted, then the joint space also is going to be lost. So definitely B is also true. There is osteophyte formation or new bone growth around the joint margins. That is typical of osteoarthritis. Osteophytes are typical of osteoarthritis, and you can see it in the finger and the joints of the finger. You can see it in any joint that is affected with osteoarthritis. And there is disruption of the articular cartilage, like we said before. That is the main problem that exists with osteoarthritis, is disruption of the articular cartilage. So in this patient, all of the above is actually correct. And as you can see on the image on the right there, that the actual space between the joints is actually very, very narrow. It should be much wider, the space. You can see close to where the yellow arrow is on the right side, you can see a little bit of an osteophyte formation. Now, if you see the black arrow, you will see that that bone looks a little bit wider than the rest of the bone. And that is because of the hypertrophy of that subchondral bone that actually exists in these patients. And then definitely what keeps the joint space is going to be the actual cartilage itself. And again, the white arrows that you see there are what's showing the eburnation. And then the yellow arrows are pointing to the osteophytes, which are very small in this specific X-ray. So all of the above are correct here. So again, let's continue talking about the X-ray findings in osteoarthritis. Remember, the joints are going to be affected unequally. Okay, so there's not going to be symmetry in the joints that are being affected. It's going to be very different. There's also going to be osteophyte formation. This is a reparatory effort of the joints to actually try to repair the damage that is being caused in the joint. And you're going to see that in the proximal interphalangeal joint, you have those little nodules, and you see it on the image that you have there, especially on the right side, the hand on the right side. You would see it on the third digit, that there is significant increase in the size of the joint. In those joints, if they have small little nodules over the joint, that is called Bouchard's node. Bouchard's. Now, in the distal interphalangeal joints, like you would see in the index finger, on the left, it would be the patient's right side, but it would be your left side. The index finger there, those are beautiful Heberden's nodes. Now let's look at another question here. The patient is advised to do which of the following? Avoid vigorous activity. Well, we know that in osteoarthritis, vigorous activity is going to cause damage to the joint. The patients are actually going to feel more joint pain, and so it is advisable to avoid vigorous activities in these patients. Now, isometric exercises with very little motion of the joints against resistance is actually much better to strengthen the muscle around the joint. Then losing weight is going to be important as well, because remember that weight will cause a lot of stress in the weight-bearing joints. The cartilage is already destroyed, so the heavier the weight, the more bone-on-bone damage is going to occur in these patients. Then acetaminophen is a good drug to give patients with osteoarthritis. It's not an anti-inflammatory, and in osteoarthritis it's not an inflammatory process. Therefore, we don't need anti-inflammatory for these patients. So in this case, all of the above is actually a good answer for these patients. Now, let's look at another question here. The patient has been using acetaminophen with little relief in her symptoms. Which of the following is the best next recommendation for this patient's condition? And we have here aspirin. Like I said before, leave aspirin, not for rheumatology. Even though in theory you could use aspirin, but it's not a good drug because of other issues that aspirin can have. Methotrexate. Methotrexate is used for inflammatory conditions. It's a non-biological disease-modifying agent, but this patient does not have an inflammatory condition. So therefore, we don't need to use methotrexate as a drug in this patient. Can we give this patient naproxen or an anti-inflammatory if acetaminophen has very little relief? Well, that could be an option for these patients. Celecoxib or Celebrex, which is a COX-2 inhibitor, should be used for those patients that actually do not tolerate regular NSAIDs. The problems with COX-2 inhibitors is that they actually shift their effect towards thromboxane, which thromboxane causes platelet aggregation and then can lead to higher incidence of cardiovascular problems and heart issues and stroke and so on and so forth. And like I mentioned before, some of the COX-2 inhibitor were removed from the market because of this issue. So adalimumab, which is tumor necrosis alpha inhibitor, is used for patients with inflammatory conditions that actually have joint pain, but osteoarthritis is not an inflammatory condition. So if the patient's joint pain does not resolve or does not improve with acetaminophen only, then you can actually go ahead and use also an NSAID as an alternative choice to acetaminophen in these patients. So naproxen would be a good choice in this patient. And again, any other NSAID would be okay. Now, how do we treat osteoarthritis? Remember that there's no cure for osteoarthritis. Once the damage is done, the damage stays there. Now, you want to reduce the pain and maintain the mobility of the patient. So really, physical therapy is going to be very important for this patient. There are a lot of non-pharmacological measures that you could use, such as reducing the load of the joints, either by losing weight, correcting the posture of the patient. Those are things that can be done. All these can be achieved through basically physical therapy. You want to maintain the range of motions in these patients, again, with physical therapy as well. You want to strengthen the muscle around the joints so that gives the patient much more stability. Remember, the articular cartilage is going to actually help the joint maintain its sturdiness. And once you take it away, the joint becomes very unstable. So if you actually strengthen the muscles, for example, in the knee, the quadriceps, you strengthen them, then the joint becomes much more stable. And then also improve their physical fitness if they do physical therapy as well. And these patients actually remember that the more exercise, the more likely that the patient is going to live a longer, healthier life as well. Now, what are the drug therapies that you use for osteoarthritis? Again, no agent has been shown to change the natural course of the disease. It's not like the other inflammatory conditions. The first line drug that we're going to use, is, as we mentioned before, is going to be acetaminophen. NSAID should only be used to alleviate pain, not for their anti-inflammatory effect, because the disease is not an inflammatory condition. Use caution when elderly patients because GI side effects of NSAIDs are higher in the elderly patient, ulcers, bleeding, and then just in general, NSAIDs actually can cause renal problems as well. So you have to be a little bit careful, and you want to use that if the actual acetaminophen at the beginning does not work for those patients. Remember that COX-2 inhibitors may be used for those that have greater risk of GI complications from regular NSAIDs. And Celecoxib is the only one that is available in the United States at this moment. And there used to be a few that were removed from the market, though. Other modalities of treatment that can be a little bit controversial, but can work in some patients. If they do work, they're very innocuous and can give the patient tremendous relief. So the capsaicin cream depletes the local sensory nerve endings of substance P. So these patients actually do not feel the pain as much as if they don't use this. Then orthopedic surgery and arthroplasty of the joint, and then just joint replacement. In those patients that have very aggressive medical treatment which has not been satisfactory, you probably are going to recommend surgery, especially if it compromises the quality of life of the patient. And most of the time, we ask a few questions to the patient, such as, is the patient able to live independently, or is their osteoarthritis has limited their independence to such a degree that they can't live independently, they can't make phone calls, they can't actually go shopping for food, they can't take care of themselves, dress themselves, proper hygiene because of their limitation. In those cases, to try to maintain patients' freedom of living independently, then orthopedic surgery can be recommended. Remember that patients that are elderly are at much higher surgical risk than patients that are younger. And so you have to be a little bit careful. And not only that, all the complications of orthopedic surgeon of the lower extremities that can come are just tremendous. So you have to be careful with how you actually address this on these patients. other modality treatments, which can be a little bit controversial as well. But in some patients, they seem to actually fare very well with it. Intraarticular injection of hyaluronic acid when they are not responsive to pharmacological therapy. The effectiveness of hyaluronic acid has been questioned since large clinical trials have failed to demonstrate superiority over intraarticular injection of just saline. So therefore, there is a little bit controversy there. Sometimes there could be a placebo effect from just the injection of the hyaluronic acid, or it could be that in some patients it does really work. So it doesn't hurt to actually give a trial if the patient is amenable to that. But really, there is controversy. And when there is controversy, things like that are not going to be really asked on the test. And if they're asked, it's probably going to be not really a good answer either.